good friends, my good friends, my good friends. Do a little bit of everything, everything. Cause it takes a bit of everything, everything. My good friends, my
Okay.
good friends,
All right. You guys know each other?
I try like to not.
To not tell anyone? So funny. Oh.
All right, here we go.
You ready?
Yeah, we're ready.
Round
Let's
two.
do it. Round 2.
Okay.
Here we go. All right. Here with my friend Motti. We are live in Denver.
Is it recording?
Yeah, it's doing it. It's doing it. We're
Okay,
good.
beautiful.
I think we're good.
Okay.
I think we're ready to go. What's going on, my man?
Well, thank you for having me, Ben.
What's been happening?
Denver specifically,
Just in general?
the fact that we've got so many vendors here who are focusing on technology and on automation, and so many providers here who don't really understand what that means.
What? I elaborate.
I think it's we've had this discussion before about like the
Yes.
sexy terms of the year, and so a couple of years ago it was bot technology. As
Yep.
providers, we really didn't understand what that meant, and now
Right.
we've got technology that's doing work that people used to do. Now it's automation,
Yep.
and when we took stock of our portfolio of what we thought was automated, and then we started talking to other people who have automation, and we realized we had even more than we thought. And some of that is because of Epic. We're an Epic user, and when you're using Epic, part of the standard is, work queue rules and things like that.
Right.
When you talk to some of the folks that are providing that outside of Epic, that's their automation. So their secret sauce is taking lots of information and making it easier for operations within RevCycle to digest and use. Epic's been doing that for a while. They just consider that part of their basic package. If you don't use what Epic has, or if you don't know how to use what Epic has, then you've got to look for alternatives.
Right.
If you don't have Epic, then for sure you got to look for alternatives. But I think that's the wave, at least for the next couple of years, is how to decrease cost related to RevCycle, so cost to collect. And then the bigger topic related to that is that we're moving services from inpatient to outpatient. So my number of touches is staying the same, but my cash per touch is going down drastically.
Right.
So in the past, authorizations, I put an army of people to get me auths, and I got all my inpatient auths. That's how we made the money, and so it was worthwhile. Well, take 50% of your orthopedic cases, push them to an outpatient service. I'm getting a third of the reimbursement. I can't afford to have that many people doing authorizations now.
Right.
And so automating that process is key.
Have you seen, I'm just assuming you've seen a lot of pressure on just cost reduction in general because of what's been happening. Like nursing costs went up.
Yes.
I heard a number yesterday that nursing costs have gone up 60% in a year.
Sometimes that's low, but yes.
So and it's not like the nurses are doing more. So the reality is somewhere there's going to have to be like costs coming out.
So not only are they not doing more, but it's the same nurses. So I have nurses that left our health system to go work for the vendor that we're now paying double per hour for the nurse.
Right.
Same person showing up to work, and now there's a lot of animosity between the nurses because of one's getting make a lot more than the other. But those costs are now baked in, right? In other words, when we're budgeting for the next year, we're assuming those costs. We're not assuming those costs are going away because they don't look like they're going away, which means costs everywhere else have to be curtailed drastically. One of the things I like about RevCycle, unlike lots of other areas in finance in healthcare, we have benchmarks. And so if you look at some of the benchmarks that exist for cost to collect, even if they're not perfect math, right? Some have HIM in, some don't have HIM in.
I would argue that it's not good math, but...
It's not good math, but it's directionally good.
It's
something. And so if you look at your net collection rate and you look at your net collection ratios and you do some math and you're below some percent of some sort of cost to collect for every dollar, then at least you have some sort of benchmark or understanding where you should be. So I think HFMA used to publish like 2.5 to 3% was a good sweet spot. I challenge that now because with so much outpatient work, you end up having to pay more.
Yeah, it costs more to
collect the same amount of money. But even with that, okay, so make that range 2 to 8%, right? If you're at the high mark and you're not meeting your KPI, then spending more is not going to help you. If you're at the low mark and you're not collecting KPI, then you probably need to spend a little bit more in order to make the dollars that you're supposed to be collecting. The easier part for me, from a rev cycle perspective, is I can calculate it at least. I have some sort of range. You speak to folks in accounting, in treasury, in supplies, in all these supply chain management. They don't have benchmarks like we do. They don't know how much they should be spending, both on labor and non-labor expenses, to be able to say, okay, I'm benchmarked, I'm spending what I should be. I can't fix your nursing cost problem. I can't fix your lack of availability of staff in your radiology centers because you can't find radiation techs.
Right.
OR techs are also hard. I mean, that's also another thing, by the way. The nurses aren't the most expensive part. It's the nurses and all of the techs that are now working as travel, charging way more on labor expenses.
Surge techs, and you just start going down the list.
So, are we looking for ways to decrease cost in rev cycle? Absolutely. Is it a dire need for the health system? No question. We're spending, 2.5% of a $5 billion organization is still, $100 million. So it's still a lot of money to collect. So
yeah, but you're not going to save it versus like clinical operations is going to have to change somehow. Right?
That I think is where,
because there's even if you took out 30% of your cost, it doesn't.
It's not going to make enough of a difference. Correct.
It's a drop in the bucket for what they actually need to take out.
Correct. And I think those are the more challenging conversations that I don't think healthcare has been willing to have.
No, well, it's like I always say, it's like moving a cruise ship, right? It takes like a long time to get it moving because the infrastructure of acute care is so large. And it's also the thing where it's like you need so much money every day to keep the lights on. So if you don't make that in some form or fashion, just to keep the lights on.
Well, I mean,
just the sheer overhead of like maintaining inpatient floors.
If you read some of the published numbers in the past few months, Kaiser was posting $1 billion loss for the first quarter.
Oh yeah,
you've got these like huge
They're
losses.
All doing it.
Everybody's losing a ton of money from their operating revenue, and the next statement is where can we save money on? But no one is saying, where can we change the way we deliver care? How do we change our care delivery models so that in 5 to 10 years, in 5 to 10 years, it's got to be a 10-year plan.
But see,
it took 10 years for us to get to this point.
A lot of those guys don't have lifespans where they can afford, they just get fired. The difference I always think is in not-for-profit, which is most healthcare is not-for-profit, let's say. The difference is it's not your money. So if it was if I had a bigger pot at the end where I had this equity payout where it's 5 years I'm going to put all this investment in, I know I'm going to lose money for 3 years because in the fourth and fifth year, I can have an exit or I can sell it or I can do whatever. You can do that. If you're a CFO today, you can't take a 3-year loss. I mean, unless you had a really visionary CEO and board that was this is what we're going to do, and we're going to shift everything. I'm sure there are organizations out there, so I don't want to say that.
There are definitely organizations out there, but I think that's what it's going to take. In other words, the concept of budgeting 1 year at a time and of planning 1 year at a time, but having a 10-year plan that you don't really stick to because everything else gets in the way, I think those things have to change. I don't think we're going to survive, $300, $400, $500 million operating losses for the foreseeable future without making some major changes. And those changes don't come in a year. Those changes are 5-10-year plans on major shifts. The opening remarks yesterday were about technology and changing the way we care for patients. And I think that's got to be at the forefront, right? And it's not just telehealth and telemedicine and hospital at home and home care and things like that. It's how do you merge all of that together where your overall cost to provide care goes down at some point in time, and that's not a one-year conversation.
Yeah. I just think I will say what the pandemic did prove is we could make significant change very, very quickly. Whereas telehealth had no traction for 10 years. We had the tech. I mean, it wasn't as good. It was more, it wasn't as easy, but we had the technology to pull it off. And overnight, people did more more visits in a week on telehealth than they did in a whole year the prior year.
And
so I know we can get rid of the bureaucratic red tape, right?
Well, so go talk to some of the payers in Medicare and let me know about the bureaucratic red tape. But that was the hardest part, right? As providers, we are normally ahead of the curve on coming up with new ways to provide care and get access to patients, because that's what the providers as physicians for sure are constantly thinking about. But when the hospital CFOs hear that we're not going to get reimbursed for it, they're not jumping on board to change the way that we provide care. So I think some of this is going to come down to just payment model shifts.
It's all about the money.
Listen,
it's all about the money.
we're rev cycle finance people. This is what it's about. But unfortunately, that's what it's come down to. It's if you can't afford, if you're not going to get paid to do the care, then you can't afford to keep your doors open. And so if you're going to shift things to technology-based services like telehealth plus, right? There are health systems out there that have, their EMS is no longer just transporting patients.
Right.
They've got paramedics showing up and treating with the help of telemedicine and leaving the patient in their house. But the way that you make money, or the way that you cover your costs for EMS, is to charge for the transport, the medications, the IV, the interventions, and then the ED visit and all the interventions there. If we're not going to make up for that revenue, having a paramedic come to the house with the doctor on the phone or doctor online and FaceTiming, we're not going to get to cover the cost for the paramedic. We won't cover the cost for the ambulance. We won't cover the cost for the doctor. And so there's got to be shifts in the way that we get paid for these services.
Well, it's the fight for that everyone is going to be doing. If I own an ambulance company, I'm fighting for the revenue to stay not the same, to grow every year. So the incentives of changing that big complex system is just it's so hard. I don't really know how they're gonna.
I was talking to somebody this morning who said it feels as if healthcare is going back 200 years. The days where the doctor came to the house with their bag and treated the patient in the house.
Right.
Most patients, when you see some of the surveys going around, they would way prefer being treated at home and having somebody take care of them at home and not have to go in the hospital, especially if they're not, ill to a point where they can get care at home. Hang an IV bag with medications does not require a hospital. Being monitored with an EKG does not require a hospital. And so those services can happen at home. People would want them at home. We just have to figure out how to change the model so that the EMS guys aren't upset because there's not enough runs. The ED physicians still have work to do. Right? We still need emergency departments, but if we shift all this volume, we're not going to afford to keep EDs open.
But you said budget earlier. It made me think of this. So I used to work at a health system as VP of Rev Cycle for a little while, believe it or not. Most people listening to this probably don't believe it, but I was. But I had a friend who ran the cardiology division, right? Young guy, administrator. And he's like, Ben, I'm just not incentivized. He just described what we just said. He goes, in my budget, it's not revenue really, it was number of procedures and where. And he's like, I have no incentive because I'll miss my budget to push these people to an outpatient center.
Right.
Even though I know that it's better for them, it's more convenient, it's all the things that would be we would say, yes, you should do that. But the budget I have is set up so that I'm not rewarded for any of that. In fact, if anything, I'm penalized. I'll look like I missed my budget.
Yeah. You'll miss your revenue numbers, you'll miss
and I'm like, oh my God, because you said, well, you have to think of at a larger budget. I'm like, No, like the actual budgeting process is part of the problem
I totally agree.
because it's not set up for big changes, fundamental shifts and change. It's not set up for that.
But now is the first time where we're forced to rethink all of that anyways, right? In the 25 years I've been doing what I've been doing, every time you start budgeting or forecasting the following year, you took the past 2 years or 3 years, you had a run rate, and you figured out, okay, my average is, and that's why I'm going to do this for next year.
And I spent it.
Right.
How many times have you heard within a hospital? How many times have you heard this where they're like, "Oh, I got to spend this money, or I won't get a budget for next year."
I gotta buy paper for next year.
Like, what are you talking about?
I've
You
got
have
to
to spend the
prepay
money.
for my audit services for next year because if I won't have that budget money.
I don't spend that money.
Yep. So it's a broken budget process, but now it's broken because we have nothing to forecast against. No one knows what our volume is going to look like in 2023. No one can predict inpatient volume, ED volume, CMI. We don't know. Our case mix is constantly changing. Our payer mix is constantly changing. So we don't know enough run rate in the last 2 years with the pandemic and quote unquote post pandemic. We don't have a run rate yet to gear or understand what our next year is going to be like. So if there's ever a time to stop the old budgeting process and to say,
hey, maybe just take a new look at it.
Like take a new look and figure something else out. And then also take a look through the 5-10 year plan. Don't look at it as saying, what do I need for 2023 in order to just maximize what my revenue is going to be like in 2023.
Yeah.
Look at 2023 through 2027 and budget, forecast your finances that way. Then one thing, again, this is like my soapbox, I don't have to be right. It's much easier to predict a 5-year plan and give the reasons of why my 5-year plan makes sense and then finance that plan than to say, I'm going to put all my eggs in one basket and I'm going to make believe 2019 is going to happen again in a hospital or in a health system. Because then when 2019 doesn't happen, the sky's falling again.
Totally.
It'll be 2022 all over again. And so
I think people thought it would just, even I thought this. I thought like, oh, there'll be this significant pent-up demand and there's going to, just like the recession, if you remember the recession in 07 and 08, it was like, there was a drop of, like small in like healthcare terms about revenue, but like there was a pretty big drop in like elective services because people were like, didn't have money. And then we saw like the whole comeback from that was like significant, right? Like blew up because people had this pent up demand for this stuff. I didn't get my knee surgery because I was like, I didn't want to pay the $4,000 out of pocket.
Right.
What's interesting about this is it doesn't seem to be the same situation. It's like people are still not coming back fully.
But I think that the situation's a little different in this case. And I think
it is much different. I guess my point is much harder to predict.
For sure.
Because we all thought it would just be 2019 return.
So here's the Motti theory, right? This is not true.
I like this. Trademarked?
This is trademarked, right? No, but it's not proven. But here's my theory. I have a couple of theories of what happened. Number one, our sickest patients, unfortunately, died. The first groups of people to die of COVID were the sick people, were the people who had a whole issue of comorbidities that existed.
Which, let's face it, is a lot of revenue.
That's how we make money in healthcare.
Revenue, quote unquote.
That's how we make money in healthcare. Those patients fill up our hospital beds, they fill up our EDs, they have procedures, they require care that costs money, and we're able to bill and make money off of it and keep our doors open because of those people. A lot of those people are gone.
Yeah,
that's stage number one.
Right.
Stage number two, during the beginning of the pandemic, when everybody was staying at home with masks on and gloves on, a lot of people who were going to become sick
didn't get sick.
A lot of our cardiac cases were not outside playing ball getting hurt. We're not on construction sites getting hurt. We're not doing the things that normally they have done that would have required maybe knee surgeries and hip replacements and things like that.
Right.
We saw that with workers' comp. Our workers' comp just there's like nothing left in workers' comp because no one's going to work.
No one's going to the office.
No one's going to the office, so there's no slip and falls. But in healthcare, those were part of what made revenue. And so that revenue went away. And then our third part was the finances. People, for the first time, because of the pandemic, sat at home or started working differently and saying, if this lasts for the next 5 years, how much money do I have in the bank set aside in savings to be able to do this again, and or to be able to afford the things that I want to do? And I think that's where, you talk about the financial downturns of the past, that's where the pandemic has not ended. We're not yet back to a point where everyone who left the workforce is back. We're not yet to a point where everyone that's needed for the workforce is back. And so when that happens and the economy goes back to whatever normal is going to be,
right.
That's when I think you'll end up with additional revenue coming from patient volume. But until then, we're making assumptions on patient volume that I don't think exist.
Right. How do you get around? I mean, how do we start to this is no shot against CFOs. I'm not trying to make a shot against them.
No.
But I think most of those people probably they weren't trained to think this isn't a thing that they're like, oh yeah, I totally know how to.
This is where the CFO.
The skill set doesn't.
Yeah, this is where the CFO has to become an operator.
And isn't that what I've seen more and more of the younger generation being more they're really into operations.
If again, theory, right? Here's a theory. The theory would be, if you look at your operations and you see that your patient volume for certain type of inpatient surgeries are now happening in ambulatory surgery centers. If you're a CFO and you believe they're all coming back, it's not happening. And there are CFOs that I speak to currently who are still saying, no, all that volume that left, they're going to return. It's not returning. Not because of any other reason than the patient doesn't want to do it and the physician has no need. The physician now has a way to do more procedures with less red tape and less planning and less prepping.
Yep.
An ambulatory procedure in an ambulatory setting happens much smoother than when you have a hospital setting.
Right.
Just as far as time goes, let anything else. On the provider side, they can show up 5 minutes before the procedure, do 5 procedures and leave. At a hospital, they've got a lot more work to do when it comes to prep, when it comes to getting to their suite, things like that. I think that's a big one. And then patients are saying, wait, I have a lower out-of-pocket expense. I can be home same day. And it was the same procedure last year that had to be done in an inpatient setting, and now no one's doing it. Why would I go back to that setting? And so if there's a primary care doctor or an orthopedist who's saying, okay, you're going to get scheduled for a procedure, and it's going to be at hospital ABC, and you got to come in at 6 in the morning and not eat since the night before, and blah, 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 and you don't get home till 4 o'clock in the afternoon, and you may stay overnight. And then you go to your second doctor, who's part of an ambulatory surgery center, who says, no, come in when's good for you? 2 o'clock in the afternoon? Okay, we'll do surgery 2 o'clock in the afternoon, you'll be home by 4. I think the shift from the CFO mentality is the patient care and the revenue is going to be meeting the patient where they need and meeting the provider where they need. And it's no longer we're the big box and everyone's going to have to come to us because we supply these services.
It's almost like they have to have some foresight and support, again, CEO, board support, to be able to strip down some of the infrastructure that exists, or the I don't say patriarchy because I'm like, it's like a thing. There's a whole hierarchy within just a hospital. Think of shifting some of that stuff. You're moving someone's cheese big time, each time. But you have to be willing to, like we said earlier, you have to be willing to make those calls. Otherwise, you're going to be sitting 2 years from now, and you just lost $1 billion. You don't have any prospect for how you're going to get out.
There is no way to get out. It's not like in the past where it was some secret.
Raise our rates.
Yeah.
We're going to do some strategic pricing. Remember that? Remember strategic pricing?
Sure. Renegotiate some contracts.
Yeah.
We're headed in a totally different way. We're renegotiating contracts for value-based payment structures and pay for performance.
Right.
That is not going to include moving all our procedures back into a hospital, or even keeping them all in the hospital. And it's going to include post-acute care. I think at one point we had in this country 1/3 of every hospital inpatient bed was behavioral health.
Yeah.
Right? And our goal in acute care hospitals is get them to the right setting, because they shouldn't be in an acute setting with behavioral health. It's not the place to treat them. And we're not set up for that. The whole health system, health systems in general in America aren't set up for that.
Well, behavioral health isn't set up for.
Right. So then
it's not. There's not enough doctors. There's not enough. All of it.
Well, why? Why are there not enough doctors?
We don't want to pay for it.
There you go. So if there's no revenue base for it and you're not paying them,
we literally shut down psychiatric hospitals, which I get wasn't maybe the most humane thing, but like those people are just homeless. Most of them. There's not systems set up.
We do not have the appropriate way to take care of them, and so no one wants to pay for it.
And now the adolescent psych is out of control, which, understandably, and there's not enough. My two daughters, they both have a psychiatrist, and I tell you, if we didn't have the right type of insurance, and this is no joke, we would never have gotten somebody, never. And we're just fortunate to have the right type of insurance,
you've got
have enough funds to be able to pay for all.
I was about to say, so even with the right type of insurance, as you know, I've got some kids as well that need help, and it's a fortune. And if you don't have the means,
we go through our deductible and stuff before like the first quarter.
Yep,
I'm like, how?
Yep.
It's crazy.
And then meds the rest of the year and more. Yeah. So the costs are high, the need is great, and where is that in all of these discussions? Where is that in all of these? They're for sure not in the CFO discussions, because it's not revenue generating. So it's cost reduction. How do we get these patients, or how do we get these patients help, but get them into a different setting, because this is not the right place.
Right.
But that's not a one-year plan. That's not a one-year go to the board, I have a way to fix our $100 million loss or our $1 billion loss.
Yeah.
That's a 5, 10, 15-year plan of we need to change the way we provide care to that population of patients, and it has to be okay that the revenue is different.
Right. Yep. All right, Motti. We're running out of time, which is crazy. It goes by so fast, isn't it? All right, rapid fire. I got some questions for you.
Uh-oh. Go ahead.
All right. I stole this from Brene Brown. I do this once in a great while, but she does rapid fire at the end of her podcast, so I just think it's pretty good.
Okay.
So I got a few questions. Let's see. What book are you reading? What's on your nightstand?
I am reading currently a book. I'm not going to remember the name. It's called. It's the story behind Maimonides Medical Center in Brooklyn. It's like hospital.
Are you actually reading like a hospital book?
It's a hospital
look at
book.
You.
It's a writer that was brought in to Maimonides Medical Center, which is a hospital in Brooklyn.
Yeah.
A place that I worked for.
Yeah.
Many moons ago, and the writer goes through like the real life stories of spending a year at the hospital, and
wow.
The lessons learned are amazing. It's amazing because I know all the players, which is very cool.
Very cool.
I'm like reading. These are people who were mentors in my life of healthcare finance, rev cycle, operations. I'll get you the name, but it's a great book, written really well, and
cool. All right, what show are you binge watching? Anything? Are you a binge watcher?
I am not a binge watcher. Sorry.
No shows. All right.
If I have time, I'm reading and or helping kids write papers, do homework.
All right. Favorite vacation.
Favorite vacation is anywhere tropical, any of the islands, Jamaica, Bahamas, St. Martin.
Oh yeah, those are good.
But it was a shift. In other words, when the kids were younger, favorite vacation was places where the kids would be busy.
Yes.
Now, favorite vacation is where the kids are having a good time with you.
Yes.
That's a shift.
It's a big shift.
To be able to like go hang out on a beach, and when the kids want to go parasailing, they go parasailing. We'll see you in a few hours. We're going parasailing. Have a good time. It used to be like they want to go parasailing. Okay, great.
I gotta figure this
I
out.
said to my wife, okay, which one of us is going parasailing? And we'd be like, no, you go. No, you go.
You go.
So I think that shift where we can get on a plane together fairly quickly, be on a beach or be hiking or be whatever, but the family activities.
Yeah, for sure.
And now that they're all teenage or older, it's great.
That's great.
Great vacations.
Well, thanks, Motti, for your time.
Thanks for having me.
It was a fun conversation.
Always.
Thanks to my friends at Tiger who let me use the booth, because that was nice of them. All right, brother.
Absolutely. Thank you.
That's good.
My good friends, my good friends, my good